And as far as high risk genomic features, should early intervention strategies differ in patients with high risk genomic
We
features?
do not know today in a chronic phase. For example, when we perform NGS sequencing on this patient with CNXL1 mutation, this patient have more cytopenias, but they respond, and some people are recommending transplant to these patients. The data is controversial and still not so solid. I think today in 2025, I will not make a treatment decision in a chronic phase based on these findings. We need more data and more evidence.
Mm. You spoke a little bit about molecular milestones and just thinking about precision medicine. What do you consider the most critical for guiding therapy changes in CML? Like, how frequently do you recommend monitoring? Um,
So when it comes to monitoring, I think it's very important at the beginning to do it closely every 3 months. And the reason behind it is not only to identify the milestones, but make sure patients are compliant because patients may not be compliant, and this monitoring will tell us if people are doing well or not. I will do every 3 months at the beginning by peripheral blood testing for PCR and fish testing. After once patient fish is negative or PCR is 1% or less, I will solely follow on a PCR.
mm,
I do it every 3 months till I reach what we call the MMR or T log reductions. After that, I can space it out to 3 to 6 months for the next year, and then every 6 months thereafter.
mhm. We spoke a little bit earlier about how, the good news is that people can live a normal lifespan with some of these with CML. So I'm wondering, how do you currently stratify patients for first line TKI selection, in particularly in younger patients seeking things like treatment-free
I
remission?
think for younger patients who are seeking treatment for remission, give an example, a woman who eventually wants to conceive a day. I do favor the drug that can induce deeper responses faster, like second gen TKI or even asciminib today, approved in the frontline. However, I will pay particular attention to the price because even though second gen TKI can induce faster, deeper responses, still the price does not justify this intervention. No, the dasatinib is available to us today at a generic price, and I hope other drugs will follow as well. I think, yes, in absolute way, young patient where I aim to stop therapy, I do favor a second gen TKI or even asciminib, but price is something to be taken into account as well.
Okay, so yeah, with that in mind, what strategies you mentioned second gen TKIs? What strategies do you advocate for when it comes to balancing cost effectiveness with the need for individualized mutation driven TKI
Well,
selection?
as I said to you, in the frontline, there's no mutation driven. So frontline, we don't take into account the things. Frontline, we go for the data we have. I do favor in absolute way the second gen TKI or asciminib if my goal is to stop therapy in younger patient. But price remains an issue for the American population and worldwide, and more so in American population. I think for the new drugs to be justified to be prescribed with the aim to induce treatment-free remission should not go more than $40,000 to $50,000 per year of treatment to be justified for the aim of stopping. But that is beyond my control at this stage.